when we put the platinum data, the single agent platinum data, like from the Isikoff trial, had to, compare it to the PARP inhibitor data, response rates are very, very similar, very high, in the 60% range. PFS is about the same, but it's much less toxic, to get a PARP inhibitor. So seems very reasonable if you've got a germline BRCA patient to utilize it early on. And we certainly are pretty desperate for data about what about those other germline mutations? Do they benefit or not?
Right.
And there must be
there are a number of trials ongoing. We have a trial at our institution that is open looking at that in broader, not only beyond breast cancer, but also beyond BRCA1 and BRCA2. So looking at the variety of the different mutations that fall within that pathway. And there are a number of clinical trials that are addressing that question. So I think we'll get some answers pretty soon.
And we have trials we can put our patients on in the meantime, for if we have that.
And just one last thing to talk about in the BRCA space, we do have some metastatic trials. The metastatic trial that was presented a couple of years ago, focusing specifically in BRCA1 and BRCA2 carriers, randomizing to platinum versus a taxane, showing that the outcome was much better in terms of response rate and duration of response with a platinum. So I think we need to think, we're thinking of sequencing, but I would definitely, the two things that I would have on my roster for those patients would be a platinum, and again, this is not in patients who progressed very recently, having been on a platinum in the neoadjuvant or adjuvant setting, and PARP inhibitors.
Right, the TNT trial,
The TNT
right, that
trial.
was a level 1 evidence that BRCA patients really benefited way more from a platinum than from taxane. So, differences, olaparib, talazoparib, pretty similar level of efficacy data, pretty close, and a little bit more heme toxicity with the talazoparib, particularly anemia, as I recall, which again probably is going to be manageable with some dose reduction in certain number of patients. Any other distinguishing points that you would say about the agents, or?
I guess just one other trial piece is that the BRCA study with talazoparib did allow for women who had prior history of brain metastases. So I think about 15% of patients on that trial had prior brain metastases.
That's right, and the forest plot showed that they got the same quite large benefit. The hazard ratio was in the 0.3 something range in favor of the talazoparib, which means maybe that if you have a patient with brain metastases, once talazoparib is available, of course we're going to need some more data, looking specifically at that question, but that's a very important subset, that really came out there, that if we had a choice between the two and we have a patient with brain, which unfortunately is not uncommon, that we might consider the old talazoparib for that patient. Yeah, real nice point.